And so the institution has been seen often as the medical home, when actually where that medical home is in the clinic. That's where the information is gathered. That's where the relationships are. And a trip to the hospital or emergency department is a sidebar to that medical home, and it comes back and is integrated through that medical home. And so that's why we focus now on the clinic. And we've moved regional health authority staff into the clinic, and we co-locate that so that we have the diabetic educators and the dietitian and the respiratory therapists focusing, and the public health nurses in our clinic. I always used to think, well, we can talk virtually. You know, we can email each other and communicate that way. There is nothing like face-to-face hallway communication. And when the diabetic nurses were constantly referring their patients on to the diabetologist, that stopped when they came into our clinic, because they said, you know what? Here you are. I can ask you my question. I don't have to refer. And I get it done right now while my patient waits. So basically, the first step was to actually start to look at our capacity and our access. And we needed to know our practice. We actually started to measure what is our demand and how much supply do we have to meet that demand, and how do we do our work in order to meet that demand. And so that speaks to this: don't make them wait. And there are actual measurable ways of doing that, and there's tools out there that you can use online that are very effective at getting to know who they are. This is my clinic, and we always use the third next available appointment, because the first next available appointment might be a cancellation. It's not a real one. By the time you get out to the third next available, that's when your appointment schedule is opening up. And as we started to think about it, you know, it's not bad. I mean, patients get in. We get them in if they need to. It's really pretty good. Until you measure, and we find out that our third next available appointment is 34 days. 34 business days away is our next available appointment. We look back 5 years. Sure enough, 34 business days away. Out of 8 of us, that's all over the board. So for me, it was 57 days to my next available appointment. We had one partner who had greater than 99 days, over 3 months, before they had another available appointment. And so we started to meet in our boardroom as a group of docs and think about this and say, how are we going to change that? And then something else happened. Something actually very dramatic happened. And for the first time in my 32 years in that clinic, we brought our clinic staff together for a meeting other than the Christmas party. And we started to talk about, why are we here? What's our role? What are we doing here in Tabor? And we started to say, this is what we think we need to do. And the staff said, that's what all this is about. Why didn't you say so? We've got some ideas too. And that's what happened. That's in a matter of 2 weeks, we dropped from 34 days, which had been the case for 5 years, to 10 to 15 days. And then we went for several months at between 10 and 15 days. And we always said, well, you know, the demand is high. It's summer. Patients, docs are on holidays. Patients are coming in, and, you know, we can't quite supply the demand. But when you think about it in terms of supply and demand, if your demand is higher than your supply, what happens to your wait time? It's got to rise. If it stays the same, demand equals supply, but you're just 2 weeks late. You're providing the service 2 weeks after it's been invited. So we did a number of things, and as you can see, it's not been perfect. This is about a year. We are now almost consistently 3 to 5 days to our next available appointment. And there's 3 of us that are doing half-time family practice. And in a half-time, it's pretty tough to get better than 3 to 5 days. And I think it's us that are screwing up the data here. So it doesn't look as nice. If we were to do actually just the full-time docs, we would have 0 days to the next available appointment. When we started this a year ago, we said, no way, impossible, couldn't be done. So we've had a very interesting experience around that. The next step is, so now we've looked at how we do our work, and the next step is, what is the work that we actually do? And we started to look at our patient population and the needs of our patient population, and those needs are going to vary. So my patient population is going to be different than my colleagues. The patient population in Sioux Lookout is going to be different than in Thunder Bay and in Toronto. And so you need to start to look at your own specific patient population and what you have to serve, what you have to do. And what are the protocols and guidelines that we need to do to meet our patients' needs. So prior to this project, I would get the yellow copy of emergency department from another emergency department, and there in the blank that says family doctor, somebody had written my name. And so I knew that there was this nebulous group of patients out there that when asked would say, I'm their family doctor. I didn't know how many, I didn't know who they were. It's this nebulous group out there. Well, now I can tell you exactly how many patients I have that call me their family doctor. How many are men, how many are women, how many are over 65. I can tell you how many have high blood pressure, how many have diabetes. I can tell you how many of my diabetics I haven't seen in this last year. All of a sudden, the world opened up to what I needed to do. That other piece of data, the average return rate, was a really important piece. And so we looked at the last 3 years and how often each of those people on my list came in to see me. And so I now know the average number of visits per year that I have to provide. So I can provide the appropriate numbers of appointments to serve this patient population. And if there are too many people and I just can't provide that supply, we need another doc. All of a sudden, we've got a way to calculate how many docs we need in our clinic. We were guessing before. So this whole piece has been really important to us and has allowed us to actually also define our continuity. How many times does my patient get to see me? Or if I'm not available, how many times do they have to go see my colleague or go to a walk-in clinic or an emergency department? And so, to see your own patients, we know, and there's clear data to say that when a patient sees their own doc, they're much happier. The compliance goes up. The visit length is shorter. Their chance of them coming back for the same problem is way less. I'm happier, the patients are happier, my staff is happy because at this point my team is seeing my patients as their patients. This is our patient population. Certainly, earlier detection of illness, our clinical outcomes are improving, and I really believe that there's a new sense of ownership between me and my patients around this. And certainly, if you give patients a choice between seeing their doctor in 5 days or seeing any doctor today, continuity usually trumps convenience. So the advantages are that patients know who their family doctor is, and I know who they are, who my patients are, and there's this accountability that we feel towards each other that is more than just episodic visits. I now have some responsibility to my patients around screening, and I want all my eligible women to have their cervical screening done. Excuse me. Also, my team knows what we need to be doing. So we've got this patient population defined, so we can actually define what needs they have around screening and chronic disease. We could even set up a way of measuring how well we're doing now because we've got the denominator. We've got my patient population, and so measurement becomes much easier. And actually, accountability and even incentivizing could occur, but we haven't done that as yet. So knowing our panel says how many support staff do we need? How many receptionists? And how many office assistants? What kind of professional people do we need? Do we need LPNs or RNs or nurse practitioners, or should we get a social worker into our group or a case manager? And then, what work do we have to do? What are the protocols? And we actually look at the top 10 reasons, because you can't take it all on. And we said, okay, and I'll show you a little bit later, these are the things that are high leverage. A lot of patients are coming in for high blood pressure. Let's talk about that. Let's see how we can manage that. So the next then is to start to pull this together. And when you start to actually, by guidelines, decide what is the right care that we need to provide for these patients, and let's make sure we provide it every time so they don't fall through the cracks, and let's provide it on time every time, all of a sudden your reliability and safety really starts to rise.